third time today. Jerome, great. Welcome back to the stage. Going to give us a difficult case scenario, I think, to talk about. Thank you.
Thank you. So, thank you for... I say ECD is already difficult, so it's going to be complicated, but we're going to do it. So, overview of ECD, as we all know, it's non-Langerhans cell histiocytosis. It's affecting bone, retroperitoneum, and the mesenteric involvement is not exceptional location, but it's not part of the iconic location. It's part, this figure is from this paper from Fleur Cohen with a patient with here a mesenteric mass, and you see here hairy kidney and vascular involvement. And looking at this work done in PTA Salpetria, you see that about 20% of patients can have mesenteric involvement. Regarding the biopsy, sometimes the histology is not specific. You can have fibrotic lesion. You always try to find MAP kinase pathway gene mutation with NGS. When you don't have the mutation, some biopsy can have a phosphoric expression, and there is a possible CSF1R expression on the biopsy. But as we all know, you can have an overlap with another rare condition. So this is the case of the patient. She's got 65 years old, medical condition, depressive syndrome, neurofibromatosis, and she got pheochromocytoma with surgical removal. And the ECD history started, I think, 2015 with abdominal pain, diarrhea, weight loss. But first, the symptoms were what we thought related to the pheochromocytoma. But despite the surgery, there was always the symptoms. So the abdominal CT showed mesenteric paniculitis. And in 2017, she's got a biopsy showing squamous histiocyte, no mutation, but phosphoric positive on the biopsy, and scintigraphy suggestive of ECD. So it was the lesion that the patient had. If you look at the PET CT, there is an uptake on the mesentery, and the bone scintigraphy show long bone involvement. So we conclude that the patient had ECD, and the biopsy here, provided by Jean-François Emile, showed that there was squamous histiocyte. So it was okay for us. We had no MAP kinase mutation, but we conclude that the patient had ECD. So it's the beginning of the story. Despite depressive syndrome, we try interferon, but it was not really well tolerated because hepatitis and worsening of the depressive syndrome. But if you look at the PET CT, there is it seems to be better on the initial lesion. So we stop the interferon. We start with Kineret, which also was not really well tolerated with fever and joint pain. So we stop the treatment. When you do the CT after the Kineret, there is still a metabolic response. So here we try infliximab for the patient, and after 5 infusions, she developed gait disturbance. So we made an MRI at that moment, and a lesion appeared, and this lesion was not present at the beginning of the disease. So we didn't know if it was related to infliximab or disease worsening despite this therapy. So we stop it, and you still have a response on the initial lesion of the PET CT, and then we start MEK inhibitor cobimetinib. But with the treatment with cobimetinib, there was still problem because the patient had still abdominal pain, diarrhea, which could be caused by the MEK inhibitor. She's got vertigo and fine tremor, and of course the pathologic brain MRI. So the first question was, does the patient have ECD? because we don't have MAP kinase pathway gene mutation, we don't have hairy kidney, we don't have vascular lesion, and the patient still have the symptom and still has vertigo despite the target therapy. And the other question was, are the problems related to the other medical condition that the patient had? So the first confounding factor was the type 1 neurofibrosis. So it's a genetic disease caused by a mutation in NF1 gene with multiple like café au lait macule on the skin, and the patient can have cutaneous neurofibroma. So this is the picture of the patient with the café au lait lesion, and here you see the neurofibroma. But if you look at the literature, you can have also extracutaneous involvement in this patient, in particular some cerebral tumor, vestibular dysfunction and balance issue. They can develop a gastrointestinal tumor and hematological malignancy, and they also have in 1% of the case pheochromocytoma. So the question was regarding this lesion, is this related to the neurofibromatosis? Did she develop brain cancer? So it was all the question that remained. And we think that it's important to distinguish NF1 related symptom to histiocytosis. But the patient also had pheochromocytoma, which is a rare neuroendocrine tumor located in the adrenal gland, and the symptoms are secondary to catecholamine secretion. So this is the kind of symptom that you can have with nausea, flush, weight loss, and abdominal pain, which was the first symptom that presented the patient. And you see the association with neurofibromatosis. To do the diagnosis, we have to make urinary test to see catecholamine derivative and special imaging. So this is the best test that you can do for the diagnosis, but it's really important to do it during the crisis because it can be normal if the patient has no symptom. And this is what you can see on the specific imaging with the tumor on the adrenal gland. So the treatment is surgery, which is effective in about 90% of the case. You can do some radiation therapy, and for some patients with some of other location, because it can happen, there is some trial with sunitinib, which seems to be effective. But the problem is that despite the surgery, some patients develop a contralateral lesion like 8-9 years after the initial surgery, and are the cerebral lesion related to hypertension, which is really common in this condition. So first, we had to make the differential diagnosis for the abdominal pain. So is it related to cancer? So ECD panniculitis, pheochromocytoma, another digestive cancer, or lymphoma induced by the immunosuppressive agent. Secondary, it can be a complication of the immunodepression, so EBV colitis, Whipple disease, and so on. And other case of abdominal pain like inflammatory colitis, porphyry, or angioneurotic edema. So this is the first thing that we have to do, and then we have to deal with the neurological symptom and the pathological imaging. So because it happened after the TNF-alpha treatment, we ask the pharmacist, can it be related to the infliximab? Is it cancer? Is it related to NF1? Are they secondary to hypertension? Is there a central pontine myelinolysis? Or is it related to ECD? So first, we investigate the catecholamine derivative. We did another specific CT to look for the recurrence of the pheochromocytoma. We did the infection and metabolic research, and we did a new biopsy by endoscopic procedure to be sure that there is no lymphoma. For the neurological investigation, so we stopped the TNF-alpha, of course. We analyzed over time the sodium level. We did the spectroscopy MRI to see if it could be related to a brain tumor, and the lumbar puncture, which were normal. And on the new biopsy, there is still histiocytosis with CSF1R expression on the digestive tissue. We found an NF1 mutation on the biopsy, and for the neurological issue, we conclude that it could be secondary to TNF-alpha, but possible with neuro-ECD. So because of the CSF1R expression, of course, we think about using that drug, but we don't have it in Europe, so we couldn't have. So, because of the main the main issue for the patient was abdominal pain, we try the mTOR inhibitor. So it leads to a partial metabolic response of the PET-CT, but the patient gained some weight, so we have to stop the treatment. So we don't really know what to do at that time, and we try another MEK inhibitor, which was really well tolerated with a perfect PET-CT, and the patient has no diarrhea, no abdominal pain, and a neurological improvement with that treatment. Of course, we add to the treatment the no pharmacological intervention with hypnosis session and referral to a pain consultation. So it showed the importance of personalized treatment therapy. So from this case, I think we have to reassess always the symptom and always remember that not every symptom are related to ECD progression. You have to value the histological confirmation and the specific imaging, and of course the multidisciplinary approach. And we see with that case that all the treatment that the patient received led to metabolic response, but it was not well tolerated. In that case, it was the first time I did it in my experience, but maybe the switch between MEK inhibitor can improve the tolerance, and maybe the brain penetration of the different MEK inhibitor are not equal for a patient. So maybe we can switch the MEK inhibitor, and for the tolerance, maybe as been showed today, we can propose a treatment holiday to improve tolerance. So for the first case, patients with comorbidity required evaluation. We have to distinguish progression, treatment side effect, or other condition. Consider always the new biopsy, and all therapy are not equally tolerated. I don't know if we have time for another, or I could. Yeah. So the other one is if we have time, or yeah, okay. So it's a patient. I didn't see the patient, but it's a patient from Julian, and he really wants me to present this one. The clinical context is we have seen here that it's a multisystemic disease, and we have frequently mutation in the MAP kinase pathway. You can have mutation in AKT mTOR pathway, and we know that the digestive involvement and the mucosal involvement are really rare in patients with ECD. So this is the patient. She is 62 years old, hypertension, essential tremor, and she's got xanthelasma since 2010, and the most important point is recurrent oral apoptosis since 2019, treated with apremilast. But despite this treatment, there was no improvement on the symptom. So this is the picture of the patients, and if you look at the scan, there is some hairy kidney, but not bilateral hairy kidney, and she had a PET-CT. This is not really iconic for ECD, but they say there is a radiotracer uptake on the bone. But if we look at the PET-CT, she's got here the big lymph node, so this is not really usual. And if you look at this presentation, she was really sick with that and that kind of thing, despite the treatment with apremilast. So it's not really like usual in patients with ECD. But we've got xanthelasma, perirenal infiltrates, uptake on the long bone. And this is the clinical picture of the patient. And we had a biopsy showing a two-tone cell. So the conclusion was, yeah, the patient got ECD. But this is all the atypical feature with recurrent apoptosis, parotidomegaly, and there is a colon infiltration of histiocytosis. So this is not really frequent, and this presentation is really rare in a patient with histiocytic disorder. But all the biopsy show mutation of KRAS in the blood, in the colon, or in the skin. So the conclusion is that the patient got a systemic ECD with KRAS mutation, but is there an overlapping condition? Because the presentation is not really usual. So with that kind of presentation, we have to rule out Behçet disease, of course, Crohn's disease, lichen planus, and pemphigoides. All the hematological stuff, because CMML or SMD with trisomy 8 can present with Behçet-like symptom. Chronic EBV, LCH, we can be present in the colon, or Rosed-Hoffmann disease with the massive parotidomegaly and lymphadenopathy. We had the rule-out infection, of course, and non-tolerance of apremilast. But the problem is that we don't really know how to treat patients with KRAS mutation because it's complicated. There is a lot of downstream below KRAS, and there is activation of CRAF when you treat patients with BRAF inhibitor. So the choice may be interferon, Kineret, cobimetinib, we don't really know. And if you look at the KRAS downstream, so it's a frequent proto-oncogen. So looking at the downstream, there is the MAP kinase pathway, of course. We have the AKT-mTOR pathway, which can be seen, as we all know, in ECD. But the KRAS mutation, Francesco, look on the cohort, it's really rare. It's less than 3% of the patients, and we don't really know how to treat them. But what is really important is this here, the expression of BCL-XL in patients with a KRAS mutation, and it's really important to apoptosis. And so what can we propose for the KRAS mutant cancer? So we can propose a downstream inhibition with a MEK inhibitor or ERK inhibitor. Here, maybe we can propose some treatment with mTOR inhibitor, or a direct inhibition of KRAS, which is done in other type of cancer. But the problem is, this is a paper which was published in patients with colon cancer. If you treat the patients here just with the MEK inhibitor, there is no effect on apoptosis, and the effect on the disease is not really good. And on that model, they propose to combine a BCL-XL inhibitor with MEK inhibitor. So maybe it can be possible, because with the work that has been done and we have talked before, maybe there is some room for combination therapy, and probably BCL inhibitor in some patients with Erdheim-Chester disease, in particular maybe the patient with KRAS mutation. So the lesson learned is that digestive ECD is rare and can be confirmed with IBD. Xanthelasma and oral ulcer can signal systemic histiocytosis. KRAS mutation may justify a treatment with a MEK inhibitor alone or a combined therapy, and always biopsy and genotype all the atypical lesion. So this is a rare presentation of KRAS mutated ECD. It highlights the diagnostic delay because the xanthelasma was in 2010 and the diagnostic was made really recently, and maybe we have to consider ECD in unusual IBD presentation. Thank you.